It's been a long time, hasn't it, before you see people in the flesh? It's been all virtual and distant, and it's quite nice to all get back together again. So what am I going to talk through? I'm going to talk through interventional radiology. That's obviously my passion, what I'm interested in. I'm not going to go into great depths of all the research and trials and stuff. I don't think that's what today's about. What today's about really is getting a flavour of what's available. So getting an idea, the kind of treatments we deliver, how we deliver them, and what that would feel like to you if you have to go forward and have one of those treatments. Okay? This is what I think interventional radiologists are like. We're like, you know, we're like the sort of Ghostbusters of the hospital. So it's a completely new subspeciality, really. So it started over the last 10, 15 years. If you come into Southampton, one thing I'm really proud about, this was taken only yesterday. Southampton has now been accredited as one of only 2 UK centres for interventional oncology. And I think the reason we've been accredited for that is because we've got expertise in lots of different areas. And as experience has grown since we've been running Planet, since we've been interested in net tumours, the volume of work and knowledge we've accumulated has made a big difference to the way we deliver the treatments and the safety, which I think is a great thing. And it's a great acknowledgement, not for me personally, but for the team, that we've now been recognised by the European body for being the best unit in the UK. Who are you going to come see? If you come into Southampton, it won't always be me. Who knows? Has anyone seen Sachin Modi before? Looks about 15. He is qualified, believe me. He always wears one of these ridiculous superhero hats. Some people think it's a religious thing. I said, no, it's a superhero hat. So you might get to see him. Tim Brant, I think that's Layla's favourite. Tim Brant is a bit of a mad sports freak, does a lot of cycling and rowing, but does a very similar job to me, delivers lots of the liver interventions. So what is interventional oncology? As I said, it's a new area of medicine. Up till now, cancer care has been reflected in 3 main specialities. So medical oncology, so Judith's just been here, isn't she? She's a medical oncologist. She delivers tablets or injections to treat cancer. There have been surgical oncologists, guys like Neil, that chop cancer out. And then there have been radiation oncologists. Those are guys that use radiation, so normally external beam radiation. That's radiation you shine at tumours to kill them. And now we've got a new way of treating tumours, and I like to think of it as almost like organ-specific, or we're developing or delivering a treatment on the basis of your anatomy. So we get into the blood vessels of the organ, find where the tumour is, and treat it that way. So that's how I like to think of our sort of new subspeciality. You all know this. NETs occur in 2 main places, really. In the pancreas, so pancreatic neuroendocrine tumours, or in the small bowel, so we call them carcinoid tumours. That's an old-fashioned term, but people use it all the time. They can develop in lots of other places, but those are the 2 big areas. We look at neuroendocrine tumours, and we first of all work out where they are, where they've spread to, and then we look at the biology of them. And the biology, as you know, we can break down according to how many replicating cells there are when we look at the tissue down a microscope, and that gives us a grading of the tumour. The other thing that's a good handle is if you have a scan and you have a scan 6 months or a year later and not much has changed, as some people have told me today on their follow-up scans, that's probably the best clue that actually the tumours are behaving themselves. When tumours start misbehaving, and I mean they start growing or they start spreading, that really is a sign that you've got to start doing something proactive about it. So the proliferation index, or the grading of the tumour, though, does give us a fairly good marker of how that tumour is going to behave. So, what we're going to go on to is what are the goals of our therapies, interventional radiology therapies. When we look at intra-arterial therapies we deliver by a blood vessel, the first thing we're trying to do is reduce the amount of tumour you've got in your body, or the amount of live tumour, the amount of growing tumour in your body. Always we're thinking about, can we get rid of enough tumour bulk to mean I can hand someone back to Neil or back to a liver surgeon or a pancreatic surgeon and say, listen, there are only a few bits left, can you get rid of all of it? Because that obviously potentially means you could cure someone. And the last bit we do is we're quite good in interventional radiology. We're basically plumbers at dealing with people's symptoms. So if symptoms of blocked bile ducts or blocked bowel or blocked tubes, we can often deal with that in interventional radiology. So symptom control is also another thing we can deal with. And if you've got a lot of tumour in your liver and it's causing lots of flushing and flaring and making people feel lousy, you can make them feel better by killing off or reducing the amount of tumour that's alive and growing in their liver. So the main treatments that we deliver via the artery are to kill the tumours by killing their blood supply, and we can either do that with bland particles, we call that TAE, transarterial embolization. We sometimes mix chemotherapy in with the beads, so they're chemotherapy impregnated beads, so that's transarterial chemoembolization or TACE. And then there's a last form of treatment, which is radiation treatment. Those are very small beads which have a high dose of radiation in them. And they work in different ways, but they're fairly similar in how we deliver them. Okay, the logic for treating liver tumours, or the advantage I have, is the liver has two blood supplies. So when you've all had coffee and cake now, all the blood from your gut, with all the goodies in it, all the glucose, all the things that you've just broken down, are coming back up the portal vein. That's the vein outlet of the bowel, back to the liver. And that's because the liver is like your main sort of engine of your body, and it's then taking some of those nutrients out of the blood that's come back from the bowel, dealing with them before it pushes it back into the circulation. So the portal vein blood, the blood coming back from the bowel, is the important blood supply for the healthy liver, because that's where it gets all its goodies from. The liver artery is actually a very small vessel. It's only about 10 or 20% of the liver's overall blood supply, but that's where the tumours get all their blood supply from. So for me, if I go into the liver artery, if I put anything in there, the vast majority of that will go to tumours rather than healthy liver. So that's a real advantage we have when we're treating tumours in the liver. And there's a diagram to show you that. So the arterial blood supply, which has got lots of oxygen in it, like everywhere else that you've got an arterial blood supply, only about 20% of that blood flow to the liver. About 80% full of the nutrients is coming back from the bowel up the portal vein. And that's the bit that the healthy liver likes, okay? So that's one of the advantages we have when we're treating liver tumours. Can't remember why I put this slide up. This is what a tumour looks like. So when you have, most of you, when I say most of you as patients will have had CT scans. You get that funny feeling, you get the injection in your arm, you suddenly feel all warm and flushed, then you feel like you wet yourself. That's because we've injected contrast. And it's that contrast that lights up blood vessels, so that's the heart there lit up, that's the aorta, the big blood vessel lit up. This here is someone's liver, and that's a tumour there, and the tumours also light up. So neuroendocrine tumours in the liver light up like light bulbs from our perspective as radiologists. And that's one of the hallmark of neuroendocrine tumours. Have no idea what that is. It's obviously, oh, this is an angiogram. So this is me injecting into a blood vessel. So this is a catheter that comes up the big artery, the aorta. We're then injecting here, and there's a big tumour here. And as you see, as we go through, can you see how the tumour goes incredibly black? And the reason for that is it's sucking up blood, and when I inject X-ray dye, it's sucking up X-ray dye. So the tumour goes incredibly black because it's got such a rich blood supply. And that's obviously an advantage to me, because it means when I inject something, it will all go to that tumour. How do we decide who are good patients for these treatments? Well, you can imagine it's quite a complicated algorithm. That's why we all sit down and have those MDTs. We all like to sit down and procrastinate and, suck our thumbs and make a decision about what's the right thing. But often you make better decisions as a group than you do on an individual basis. And that's the advantage of an MDT. We all sit there. Some people think one thing's a good idea, some think another thing's a good idea. It's a bit like the Conservative Party at the moment. We all argue about it, then eventually we come to a consensus. Unlike the Conservative Party, we probably all agree to go along with that. But I mean, the good thing is we look at, there are things that mean definitely you shouldn't have these treatments. If your liver function's bad, so you've gone yellow, you're jaundiced, or the liver's failing, you shouldn't be having any of these treatments because it'll just make you worse. If you're not feeling strong, so I like to see people that are, walking into clinic, they're still enjoying life, they're still playing golf, they're still doing things, that's a really good sign. If someone's almost bedbound, that's not a time to be having an invasive treatment because it's just going to make you feel worse. And we like to see that there is the vein supply of the liver, so the portal vein supply is still alive. So if you have a blockage of the portal vein, then we're a bit more cautious, because then the healthy liver's getting its blood supply from the artery as well. There are some relative things. These are things that make us more cautious about liver treatment. One of them that's important for patients who have had pancreatic disease is this idea, if you've had a Whipple's operation where they've taken away the head of your pancreas, they then plumb the bile ducts back onto your bowel, so the bile can get out of your liver again. The only problem with that is it also means when you have fish and chips, that can go back up towards the liver. So that means that if you've got a stent in your bile duct or you've had a surgical reconstruction, then there's a much higher risk that if we treat a tumour in the liver, that it can get infected. So that's one of the things technically for us that makes us quite cautious. I put this up because this is a tumour, this is someone's liver, and you can see over 50% of that liver is tumour. Now, in almost all other cancers that we treat, someone who's got very extensive liver disease, we wouldn't treat them with our treatments. But neuroendocrine disease is a bit different. So I think if someone's well and their liver's still working well, even if you've got over half of the liver's taken over by tumour, we can still treat people, but what we would do is we would treat them in a segmental or in a sequential fashion. So you would treat a bit of the liver, see how well the patient is, and a month later, 6 weeks later, see how well the treatment's worked. And if the treatment's worked well and the patient is still fit and strong, then you'd do a bit more. You wouldn't try and treat all of that tumour in one go because you'd make someone really, really sick. But you can stage these treatments. So unlike other cancers when you've got extensive liver disease, when we would say, listen, there really is no merit in this. In neuroendocrine disease, there is merit, but it needs to be thought through carefully and staged. So, you all know this. So at Southampton, we've got an MDT, which is great, full of people with different subspecialties, all have different inputs to care. Patients are referred for clinic. So we have an interventional radiology clinic. People come to see us in the clinic and we talk to them about the treatments. We have interventional radiology CNSs, so they're nurse specialists that look after people who are going through that pathway. They're a good point of contact. They give you a slightly different view of what treatments will be like. They're fairly honest, and they follow people up closely afterwards. So they'll phone people regularly, keep an eye on people after they've had their treatments. And that's important for making sure people are recovering just how we're expecting them to. Anyone that's been in and had any liver treatments, we're fairly obsessional about making sure we give you those injections of octreotide, those infusions. And the reason for that is sometimes the tumours, when you attack them, fight back a bit and they release a whole load of substances back into your circulation that make people unwell during the treatment. If you have the octreotide infusion, people get, it's a nuisance because you have to often come in for 24 hours before a treatment. The advantage is by soaking you in octreotide, it means that when we're treating the tumours don't misbehave because you've blocked all those receptors around the body. So even if there is a whole surge of these vasoactive substances, it has no effect. So that's the reason if you get admitted the day before for an infusion of octreotide, the reason for doing that is just to make you safe when you have the treatment. Okay. Technically, what do we do? Well, we've got a whole host of different catheters. Those are little thin tubes, all different shapes and angles. We can see those on our screen as we're intervening. So when we stick one of those catheters up your artery, we can see the end of it. We've got different shaped wires, and we can get into different blood vessels, see where we are, and then inject X-ray dye and see when I'm injecting something, where's it going to. So that's the basis of what we do effectively. I have absolutely no idea what these are. I mean, I do know it's a liver artery, I know that bit. But I have absolutely no idea. I'll just rush through them. So this is what a CT looks like. Those are lots of liver tumours. So they're the sort of bright light bulbs. I have absolutely... Is there a video on that one? There's not a video on that one, is there? No. Exactly. And I know so I know who's stolen it off me. It's Sachin. No. No. Computer says no. What it's trying to show, that's me injecting into a liver artery. The liver's there, and there's a thing there that looks like a potato. I won't say the patient's name, but Neil will remember. And that's what it looked like after we treated it. So what we did there was we treated the tumour using embolisation, so by putting particles in, killing the blood supply. The tumour then, so that's the bottom of the liver, is all shrunk down and atrophied down, and that allowed Neil then to chop it out, but preserving lots of healthy liver. So that's one way we can use the technology. When we inject particles, there are different sizes of particles. Some block big vessels, some get further down into the tumour blood supply, some get right into the tumour. So when we talk about SIRT, that's the radiation treatment, that gets right down into the tumour blood supply. Most of the bland embolisation blocks the vessel at that sort of level. What's the logic for treating someone who's got metastatic disease? So you've got a tumour, it spreads to your liver. In most other cancers we deal with, once tumours are spreading or starting to spread, we don't often treat them aggressively. In neuroendocrine disease, there's quite good evidence, if you look at people's survival out to 5 years, that people have aggressive treatment. Now, if you can operate and remove tumour, that's number one, that's the best thing, because that's the cleanest way of debulking tumour. If you can't operate because of the distribution of tumours, then if we use blocking agents to kill the blood supply, that can have the same effect of debulking or reducing the amount of living tumour. There's good evidence that you get much better long-term survival. Okay, so I suppose that's the logic for what we're doing. By, at the outset, reducing the amount of tumour you've got, that can sort of reset things or turn things back 5 years, which is obviously good news. There is one issue with blocking blood supply to the liver, is that you can cause damage to other bits of the liver. And one thing we get particularly worried about are the bile ducts. So you can cause ischemia or damage to bile ducts when you do these treatments. So you have to do it carefully, and you have to make sure you follow people sequentially. And if there's any sign of those problems, then you're much more cautious and you'd be much less keen to retreat them. So that looks like a neuroendocrine tumour to me. Actually, that might even be something in the pancreas, and there's a tumour in the liver there. Ah, okay, and that's the same tumour. Now, can you see all the black dots in there? So the black dots are actually gas. Now, normally we see gas in bits of people's bodies. As medics, that's normally a massive warning sign. There's some nasty infection or, flesh-eating bug. Oddly, in our treatments, we've killed the blood supply to that tumour using embolisation, and that tumour is then infarcted and turned into liquid. And it turns into liquid. It's not pus in terms it's not infected, but it's necrotic tissue. So people often say to me after they've had treatments, oh, my tumour's the same size. Well, the tumour would be the same size, or the hole in the liver will be the same size. It'll take 6 months, a year, 2 years till that area shrinks down, because what you're relying on is the body's immune system recognising that's a lump of dead tissue. It then attacks it, it then resorbs the proteins and things from there, and then the healthy liver either regenerates or you end up with a bit of scar tissue. But that process is a long, long process. So the first scan you have after a treatment, we're not really interested in the tumour size. What we're interested in actually is, if I go back one, that tumour there has got a really rich blood supply. It's lighting up like a light bulb from my perspective. So there's more white in there, there's more contrast in there than the liver around it. So that's the marker of a growing tumour. On the next scan, the tumour's black relative to the healthy liver, so it's lost its blood supply. So that's the bit that we're interested in first up after you're having a treatment. And with time, you can see then that it's starting to shrink down. You can see the capsule of the liver's being pulled in because that's scarring away, but the tumour's starting to shrink down over 6 months or a year. Radioembolisation is a sort of refinement on this. Now, currently, radioembolisation isn't funded by the NHS, which is a big bugbear. What radiation particles are is, rather than killing the blood supply by blocking the tumour vessel off and stopping it getting blood and oxygen, what we're actually trying to do is deliver a massive dose of radiation deep into the tumour. And so the particles are tiny, but they're little beta emitters. Now, anyone that remembers physics from school, a beta emitter is actually an electron. It's actually a bit of radiation, but it's got mass to it. And the reason that's relevant is it doesn't get very far. It rattles around inside the tumours and causes a lot of local damage. It doesn't get out of the tumour, or it doesn't get out of you. So they cause a lot of local damage. They also, the other difference is they work over a much longer time frame. So when you have embolisation, at the end of the procedure, as soon as I've finished injecting something, often patients will get pain there and then they'll feel lousy for about a week or 10 days because all those tumours are dying as we're treating them. With the SIRT, the effect is much more prolonged. So the half-life of radiation is about 2.5 days, but so the radiation is delivered over about 10 days, 10, 11 days. And then the effect starts over the next 6 weeks, and it takes much longer for that effect to mature. So you have to wait much longer to see the effect of it. But the good side of it is you don't get quite so lousy just after treatment because you don't have that inflammatory response of lots of dead tumour immediately. To do a SIRT is slightly different. The radiation is quite dangerous, so we have to do a workup. We have to do a special angiogram where we look at where the tumour's getting its blood supply from, and we put a test dose of radiation in, and we then scan to see where that dose has ended up. Radiation particles are quite small. They can shunt through to your lungs or other places. If they do that, they could cause real damage. So we have to prove that when we inject a test dose, it ends up just what we want it inside the tumour. So much the same, this is us just injecting up into a liver artery. I suppose for me, this is a little bit what interventional radiology is all about. It feels like I've got a few fellows that are like this. You turn your back for 1 minute and if you, what have you gone and done? No, that's not the reason for showing this. This is more about the idea of dosimetry. What I'm all about is making sure that we damage the tumour, but we don't do this. We don't cause collateral damage to normal tissue. It's going to take some explaining when their parents come and pick them up, isn't it? Oh, I'm sorry. So this is dosimetry mapping. So this is a CT scan. These are radiation maps of a liver, and we can work out the amount of radiation we want to deliver. When we've done a test dose, we know what the radiation marks are like in the liver, and we can then, it's literally like a rheostat. You can turn it up or down according to the amount of dose you want to deliver. But there's quite a lot of science to that. Now, these are the sort of heat maps. So after a test dose of radiation, the orange areas are where the radiation has ended up in the liver. So we do a CT scan and then a radiation scan and fuse the two together. And that shows us if you've got very focal uptake of radiation where the tumours are, that's a really good sign. Complications of radioembolisation are slightly different from bland embolisation. It's better tolerated. People get less symptomatic. But there are some other issues with radiation. I suppose the one that really we have a great fear of is radiation hepatitis. If we get the dosimetry wrong, a bit like that kid at the party, you damage the healthy liver, and the healthy liver can pack up. Now, that's a failure on my part and a failure of us doing the dosimetry, but it can happen. And that's something that couldn't happen with bland embolisation. And I suppose this is the point that actually the follow-up needs to be prolonged. So you don't scan someone a couple of months and say, oh, look, it's all going to look great. It doesn't work like that. You have to wait to 6 months or a year to get a real handle on how well the radiation's worked. Science, again, I'm not going to get heavily bogged down in this, but basically there's quite good science to show good response rates to radioembolisation. It is well tolerated. But currently, and there's ongoing arguments about that, it's not currently funded by the NHS. So the NHS will fund it for primary liver cancer. It funds it for some patients with bowel cancer, colorectal cancer, although a small group. There used to be funding for neuroendocrine disease, and we're going to fight for it again, but currently it's not funded. Last of all, just one of my little sort of pet interests is this idea of chemoembolisation. Chemosaturation, sorry. This is the idea you can isolate the liver from the body and then inject a massive dose of chemotherapy into it. So this is something we've done more in Southampton than anywhere else in the world, so we're quite proud of that. What you do is you put a catheter up the vein, the IVC, and you put a balloon in the heart and a balloon below the liver. You can then suck all the blood out that's coming out of the liver. When you inject chemotherapy into the liver tumours, it then comes out of the vein of the liver, and we can then capture that blood, suck it out of the patient with a cardiac bypass machine, clean the blood, and then give the blood back to the patient without any chemotherapy in it. So you get all the chemotherapy effect where you want it in the liver and none of it elsewhere. So it's quite an interesting technique. I'm not going to bore you with it too much, but this is it. So that's the balloon in the heart there. That's the balloon in the IVC. This is injecting, these are the veins of the liver, the hepatic vein. So this is showing that I've got occlusion. So I've managed to occlude the vein outlet of their liver. Oh God, I've got one of those dreaded hats on as well. Sachin must have got to me that day. So this is the tube. So that's the catheter that's up there with the balloons at the top end. We suck the blood out of the patient. It then goes through this is a venous bypass circuit, same as if you had cardiac surgery. So we're sucking the blood through a circuit, comes up, you can put it through these filters, so it cleans the chemotherapy out, and then you give the blood back to the patient. So it's a palaver to do, but it's an amazing technology because it allows you to deliver a massive dose of chemotherapy to the liver without it affecting the patient. So they get no systemic effect from the chemotherapy. And that means we can use much bigger doses than we could normally live. We're currently only treating patients with eye cancer, but we've done enough now. We've done over 300 cases now. We know it's safe, because when we started, we didn't know it was safe. Now we know it's safe. We are interested in trying to set up a trial for NET patients as well. But I'm not going to stand here and say that will be recruiting soon. Setting up these trials takes a long time. But I'm hopeful this will have real use in patients with neuroendocrine disease. That's a few more of the team. These are Planet's hats. So one of the great things Planet's has done for us as a scrub team, everyone's got their own hat. I'm really bad on names. So it's really awkward when you're working with people all the time and you forget their name. Because they've all got their name on their head now, that makes it, it's handy. So that's one of the things Planet's has done that actually the team love. Everyone is really grateful for that. Great. Now that's probably all I wanted to tell you.
Thank you, Brian.